Hi, it's the nursing professor here. We're going to talk today about the neurosystem. Now, many students kind of run and shy away from the neurosystem, but the truth is this: it is literally brain, spinal cord, period. It's just two different areas. And so we know the brain is kind of like central command system. Without it being able to function properly, then we're unable to do anything. I mean, even as far as breathing, or our hearts won't beat without the brain actually giving the correct signals in order for those things to happen. So let's talk about it. All right, so it regulates everything. We get that. There are disorders that happen when the brain doesn't function properly. And so many of those orders are things that we hear about frequently, like a head injury. Somebody was in a car accident or got hit with something and the brain swells, so they have a head injury. Stroke, which is also known as CVA or cerebral vascular accident. Different diseases like multiple sclerosis would be one, aneurysms, migraines, tumors, hypoglycemia and hyperglycemia. I mean, those are a result of an endocrine disorder. However, remember we said the brain controls everything. So many times we see neurological symptoms associated with hypoglycemia and hyperglycemia. Dementia, seizures, epilepsy, encephalopathy or encephalitis. So all of those are possible disorders of the brain. And so the best way to learn it is to try to group things together or like things together. So let's pull out CVA or stroke, because there's a couple of types of stroke that a person can have. They can have a hemorrhagic stroke, which really has very poor outcomes. This means like a massive bleed. So you can only imagine that if the brain is bleeding, that's pretty hard to stop, and usually outcomes are very poor. You can also have a thrombolytic clot in the brain, where that's what it sounds like. There's a blood clot that forms in the brain. So we know we have vessels all over our bodies. If a vessel in our heart gets a blood clot, then it's called a myocardial infarction. If that clot forms in one of our brain vessels, it's called a stroke. Okay? We have an embolic type of stroke where this blood clot might have broken off from someplace else and it travels. And then we have the ischemic stroke, which is a stroke that can have good outcomes, especially if it is caught in time. And so there is an assessment tool that many times is used, because if a person can get treatment within somewhere 3, 4, 4.5 hours tops, then they can get a medication called TPA that will actually help reverse the damage from that blood clot. So while we're here, let's talk about how you would do an assessment of a person who has a stroke. So the tool that is frequently used now is called the NIH stroke scale. And so it is a scale where you have 0 to 3 and the person gets points. Okay, let's see if you can see it better over here. 0 to 3. Yeah, 0 to 3, person gets points. All right, so first question would be, is that person alert? Okay, if they are alert, they get 0. If they're not alert, but they are arousable, they might get a 1. Okay, if they're not alert and they require repeated stimulation to respond, then they get a 2. If they respond only with reflex, motor, or autonomic effects, then they get a 3. So NIH stroke scale, the higher the score is, then the more likely this person has had a stroke. Of course, there are other assessment tools that we do use as well outside of the NIH stroke score scale, but that is one that's really pretty quick. Okay, Glasgow Coma Scale is also a tool that we will use, and that looks at a score of 1 to 15. Okay, and so very similar, it gives you numbers that are associated with particular responses from a patient. So where we need to be concerned with is the total. Like if anything is less than 8, that's considered severe neurological damage. If it's anywhere between 9 and 12, it's considered moderate, and anything greater than 12 is considered mild. And so just take a look in your book and you'll see the types of questions, but basically it's this, it's scoring if the person's able to open their eyes on demand, if they have a good verbal response and a good motor response. So basically those are the areas that are being assessed with Glasgow coma. Okay, all right, so other tools that are used to assess neurological conditions with brain disorders include diagnostic procedures like your CT scans. Usually it's a CT scan without contrast, MRI, MRA, lumbar puncture. Sometimes they get some spinal fluid so that they can assess to see if there's some sort of brain problem or neurological problem. And then we will come up with the nursing diagnosis, which of course could be alteration in pain, alteration in comfort. It could be alteration in mental status, which is usually something that does show up with a person who has a brain injury. Alteration in electrolyte imbalance, because frequently the sodium can be off. It could actually be very high, which could be an indication that needs to be addressed. Safety is always a concern with somebody with a brain injury. Impaired physical mobility, because sometimes those injuries prevent them from being able to walk. Self-care deficit, if you're impaired mobility, usually you can't care for yourself. Risk for infection and knowledge deficit, and that would be for both your patient and their family, because brain injuries can change people's lives. The whole role of a person can change as a result of a brain injury. So we come up with a plan. Our plan needs to be something that is obtainable, that's measurable. And so we think of interventions. Those would be, of course, pain medicine, if they're having pain medicine, physical therapy, occupational therapy, any type of rehab services, any type of assistive devices they may need in order to help them gain as much independence as possible. Monitoring their vital signs. I mean, frequently with brain injuries, you have alteration in vital signs, depending on the severity of the brain injury. And looking at change of level of conscious, maybe you assess a person at 1 hour and they were fully alert and oriented. However, 4 hours later when you go in there, they're totally confused because of the brain injury. So frequent assessments of their level of conscious is necessary. Communication, make sure they have proper communication tools, because sometimes with brain injuries, they can no longer communicate the way that we communicate now. So they might have a change in senses, like maybe not be able to hear or might not be able to speak. There are 2 types of aphasia that many people who have strokes suffer from. It's and that means they could have difficulty expressing themselves, or they could have difficulty receiving information. And so aphasia would be that type of disturbance. Sometimes you'll have problems with feeding, because if there's been an impairment, they might have difficulty swallowing. And so we would need to make sure that they have a diet that they can ingest. The texture of the food might have to change. You want to make sure that there's a low sodium, low salt, low cholesterol diet, especially if you have a person you're taking care of who's had a stroke. Angioplasty is also an option where the blocked vessel is actually widened. So the same thing can happen in the cardiac system, but it also can happen in the brain where a stent can be placed. All right. And so important to note the types of medications, the blood thinners like warfarin and Lovenox and heparin and what is the other one? Begins with an E. Can't think of it. I got a brain fart. Yes, blood thinners. In particular, know your, if a person is on warfarin, then you're measuring their PT-INR, which is their time that's necessary in order for that person to get an accurate dose of their medication. You don't want them to have too much of a blood thinner. And heparin, you would measure it by doing a PTT, which is a different type of lab test. And so you should be aware of those as well. All right, so let's also move now to the spinal column, because sometimes spinal cord injuries are also a part of neurological deficits that we see in our patients. And depending on where the level of injury is, then that will determine how much damage that the person has. So for an example, if a person has an injury where it's C4, cervical 4, or above, they are at a greater risk for respiratory problems. So many times they're put on a ventilator. And so that's important for you to know, because injuries of the spinal column frequently result in some sort of paresis, which is weakness, or paralysis, meaning that that person has very, very limited movement, if at all. So when we're talking about a spinal cord injury, we're talking about people who are suffering from lack of sensation. Their muscles get flaccid, meaning they get just almost like mush because they're not being used. Hypotension, blood pressure frequently drops, and so we need to be aware of that. So as we're changing positions, we're changing it slowly. Of course, loss of mobility, they're at risk for skin breakdown. Frequently, they will have problems with incontinence, because they won't have the sensation of needing to urinate or to have a bowel movement. And so if there's a problem with inability to have sensation related to urine, the urinary system, it is called a neurogenic bladder. And so frequently those people either have an in and out catheterization, where it's time, like every 6 hours or so, they have a catheter put in, it's taken back out, because of course we try not to leave catheters in because of the increased risk of infections. If they have a bowel system that has been impacted, then usually there's a bowel regimen prescribed such that they can go to the bathroom. Sometimes that might include manual stimulation that has to happen so that that person can expel their waste. Now, medications that are typically associated with spinal cord injuries can include vasopressors, like norepinephrine and dopamine, and they are both used to treat hypotension, meaning low blood pressure that we just talked about, that sometimes people do suffer from. Also, muscle relaxants. If you see a person who's had a spinal cord injury, sometimes they get really what we call spastic, meaning that their body doesn't move in the same way. It almost gets stiff. And so to help some of that minimize or decrease some of that stiffness, then they are prescribed muscle relaxants. Cholinergics, they help to work to decrease that bladder spasticity that you would see with a neurogenic bladder. Analgesics for pain, anticoagulants, again, are those blood thinners, stool softeners, laxatives. All of those are possible pain medicines and interventions. With a spinal cord injury patient, you're going to have the same sort of interventions to include rehab, PT, OT, speech therapy. Some of the results that you actually see, especially early intervention, are really remarkable. I mean, there are people who you think will never walk, and they end up walking with some sort of assistive device. So early intervention is the best treatment for anyone with a brain or spinal cord injury, and education, making sure that family and the patient knows what's going on so that they can adjust to whatever's happening. So I'm going to give you a question now. So this question has to do with a person who had a spinal cord injury. So listen up. A nurse is caring for a client who had a C4 spinal cord injury. The nurse should recognize that this client is at the greatest risk for which of the following complications? Okay, and it's only one. A neurogenic shock. B, paralytic ileus. C, stress ulcer. Or D, respiratory compromise. And if you remember at the top of our conversation about spinal cord injuries, then when we talked about C4, we talked about what the primary importance of having an injury at that level will create a certain deficit. So if you don't get the answer right, go back to the beginning of the spinal cord section and you'll clearly see it. All right, bye for now.